Hi, everybody. Susan Clinton here. Welcome to Tough to Treat podcast. This is going to be podcast number 137, kind of an interesting conglomeration of cases that I've seen over the years, but they have a few things in common that I think will be very helpful for people treating complex lumbar spine pain. I just wanted to say thank you for all of you who have come onto the website and signed up and subscribed. Please keep doing that. We'd love to have you there, and that's the best way to get information from us is on our email list. And so come on in, toughtotreat.com. We've got great things happening on there. We're getting some transcriptions done. We're getting the podcast organized into playlists. We're doing a lot of cool things so that you guys can find your way through our information with a little bit more efficacious searches. So We'll see you on the inside and enjoy the podcast. Hello, everybody. Welcome to November, and this is our podcast number 137. I'm Susan Clinton, the co-host of Tough to Treat with my lovely partner, Erica Mello. Hi, Erica.
Hi, Susan. How are you today?
I'm good. It's November the 7th when we're recording this, and it's snowing in northern Michigan while we're messing with getting a home built. It's all interesting and all crazy. So
oh my God,
anyway.
I know it's 72 degrees here. Totally abnormal.
But so our leaves are done. The snow is swirling. It's northern Michigan now. That's for sure. We had beautiful
I love the
beautiful
snow.
October weather though. Okay, so let's get to it. Podcast number 137. This is not a specific person, but a kind of a conglomeration of clients that I have seen, typically women in their mid-40s around that time, a lot going on in their lives, but basically looking at a lot of them with just coming in, the biggest complaint is lumbosacral pain. So we're looking at like L5S1-ish area, pain sometimes travels into the groin area, and most of them have trouble walking, increases their pain going up and down steps, but mostly going down versus up. It increases the pain after sitting times an hour, getting up from sitting, and or prolonged standing. Are all kind of the hallmarks. Yeah, exactly. So it's kind of like, what do we see? Where do we start?
Right.
Forward bend is usually okay. Squat is usually just fine.
Okay.
And then the other, special tests that we kind of do is like a lunge. When I think about walking, I think about one step, being able to stand on one leg. And so pain with the lunge onto the right. So if we're looking at the left, if they lunge onto their right leg, it's the left side that bothers them. If they lunge out onto their left leg, not so much of a problem. So we're looking at an extension problem here.
Yes.
That area doesn't like extension, and that's what's aggravating it. So when they sit flexed for a while and they have to go into extension, it's cranky. If they stand for a long period of time, it gets cranky and irritable. So those are kinds of some things to look at. Again, one-legged stance, usually what I see is an inability to control on the side where the pain is. They just can't control their pelvis. They have to lean, they have to twist, they have to do something. So we're kind of probably looking at a little bit of glute ab and, glute med and glute activation problems, probably inhibited because of the irritable pain coming through. Yeah. So this is, these particular people usually have one or two kids. So if we've got somebody, we'll just talk about one side because I see it. You can see it on both sides. You can see it on one side. So if left L5S1 area, generally they're holding their kids on their right hip. They have decreased rotation of L1, T12, L1 to the opposite side, to the right.
To the right. Okay.
Yeah. Because they're always rotated left.
Yes,
because
correct.
they're holding the kid
they're
on the right
translated,
side.
right?
Yeah,
Exactly.
right. So you can kind of. So I'm just trying to set up the picture
Painting
here.
a picture, yeah.
Like, where did that dominant pattern come in? Again, right-handed people, maybe sit and twist a little bit more to the other side.
Yes.
And so those are just some things to kind of think about. Usually have a stiff mid-thorax. So there's usually many problems to kind of rule out. So one thing is we need to rule out the fact, with the pain going into the groin area, we have to kind of consider the hip. But
Yes, of
what else do
course.
we consider? We consider T12L,
Teach
T12L1. We
one.
consider, hip rotation and hip extension.
Hmm.
Why is the lumbar spine being irritated? Generally because there's a driver above or below or both,
Yeah.
right? So it's the victim on the ends, in between. So if we've
Hmm.
got limitations in the T12L1 area, if we've got a stiff, mid-thorax, if we've got a hip that isn't extending well,
Hmm. Yep.
and doesn't have great control over it, with the musculature around the pelvis, those could
Hmm.
all be problems. We have to also think about over recruitment of the quadratus on that side, and then maybe even over recruitment of the obturator internus on the side of the left hip, or the hip external rotators, even
Yes.
as a
Yes.
functional group.
Yes.
And, because that can also have that kind of, give that kind of pain presentation coming around.
Hmm.
So we've got a hip that probably the femoral head isn't set well into the acetabulum.
Right.
It may have a posterior glide to it, keeping them from going into hip extension.
Yeah.
Well,
Plus, if they're loading on the right side more with the child on the hip, that left side loses options for movement.
yeah,
Susan, you said walking down the stairs bothered them too on the left. I mean, with the left leading, right?
yeah,
Ah, okay.
yeah, as they go into extension, coming
Got
down
it.
the stairs.
Got it.
Much less going up. I mean, you still can have the loading problem going up as they go from flexion into extension,
Yeah.
but I see it much more on the coming down.
Okay.
That's where the control, loss of control, but also just kind of like that little bit of shock attenuation problem and jarring into that area.
Yeah.
And particularly if they're carrying something on the right side,
Yeah. Yeah.
which tends to be, again, it could be right-sided and they're carrying on the left. This is kind of the pattern and how I see it get dominant in this type
Hmm.
of population.
Yep.
So the other thing we need to consider is constipation. We've got a
Mm.
left-sided problem, and if they're holding stool in their duodenum and their descending colon, that could be irritable to that area, that could be a
Yes.
problem. You'd figure that out. Does it get better after they have a BM? Is there presence of stool there all the time? So we have a group of things we need to roll through. So constipation is one of them, over recruitment, as we talked about, of the external rotators, decreased extension of the hip as on an impairment level,
Yep.
thinking about that, decreased activity or activation. I don't even want to call it activation, just an inhibition of the hip abductors and
Hmm.
maybe the glute max there.
Hmm.
Decreased rotation T12L1 to the right because they tend to
Hmm.
rotate left all the time,
Hmm.
and with the over recruitment of the quadratus. And where did we start? Here's the question that I
Where
like
do you?
to ask everybody. So I'd love everybody's opinion on this because there's no wrong answer. But
Right.
where do we start? Do we start at the impairment level or do we start at the functional movement level? I'll let
I
you go
mean,
first because there's
well,
no wrong answer. I
there's no.
just love
I mean,
hearing where you go because we get there the same way, but oftentimes we take different routes.
that's very true. Um, I would probably go more at the movement level, just because. I mean, if the person's loading, let's say they are, right, really loading center of mass on the right, and they're because of the carrying the child, that, as I said, that left side loses options. What happens? Let's say we'll pick a movement. I would pick, I don't know, step forward or a lunge or some movement that,
Mm-hmm.
they have a problem doing, and see if they are resorting to that dominant movement pattern of translation and the thorax to the right, or do they have a loss of control in the hip? Do they have a loss of control in the back foot? Right.
Mm-hmm.
So
Right.
that's how I would start, you
Mm-hmm.
know. And what is their impairment? Is it an overactive something or an underactive something, or both?
Or both, exactly. And I think when we look at this region, it's always both.
Yeah.
Maybe they're not turning their abs on. I don't know. We can get into all that timing business as much as we want to, but I think, kind of thinking about that, and that's stuff we do right in the assessment, what you were talking about. So definitely a lunge is something you want to assess and you want to look for that. What's happening to that thorax? Does it change? Does it translocate back to the middle? Does it stay stuck into the position that you're seeing and standing and bending over and
Right.
those things, standing on one leg and then, looking at the foot
Right.
and
Yeah. And does that
Mhm.
movement pattern that you're seeing, is it dominant across all of those movements?
Exactly.
And it probably is
Hmm.
generally.
Trying to find the the drivers here, but also using that assessment to guide intervention. And I know that's one of the things we hear a lot from our listeners is how do you know where to go and how do you progress, which is why we've been doing a lot of these lately, particularly on progressions. So lunging is a beautiful place to start and looking for those across those movement patterns. So where do I start? The first thing that always happens for me, just because of my neuro background, is my primary thing is always to help that person gain rotation in the side that they're missing it. Because without it, we're not going to get anywhere. It's just, in my opinion, we're not going to get the muscles to recruit differently. Rotation just really can be such a valuable thing. Now, here's the thing. You can get rotation at the impairment level, or you can get it at the functional movement level.
Right.
So you can do either, both are right. You just need to make sure that when you're doing it in the functional movement level, it's making a change in what you're seeing in that movement pattern across all those positions, right?
Yes.
If you're doing it at the impairment level, you need to go back and reassess those movements to see if it changed.
Yes.
You may have given a nudge into their neurological system by doing the impairment work, but if it doesn't change in the functional movement, then you can bang away for days and not get it to change. So they go hand in hand. We have to have the movement there, but it has to also have meaning in the system.
Right. So you're saying, just for the listeners, you're saying that at the impairment level, you see that they're obviously reduced rotation to the right. So you would go in and restore that, however means we do that, and make sure it carries over to functional movement patterning versus going into the movement patterning and trying to restore it in that movement pattern.
Yeah.
Got it.
And you can do, but both work. So
Yes,
if you're trying to restore it and it's not happening, you may have to go in and work at the impairment level a little bit and then come back out.
Yeah,
and
agreed.
But they work. There's I know everybody always wants the algorithm, okay, I work on the impairments first and then the functional movement patterns and then this stuff, in that line. And it's we got to do it together, because if it's not changing it, we're wasting our time.
Yeah.
And we're wasting our clients' time, quite frankly.
Yeah.
So go ahead.
No, I was going to say, you have to figure out why they're lacking that rotation. And obviously it's because of this, carrying on the hip. But is it underactive, overactive? Do you need to sit there and release, or do you just need to train a little bit and do some neuro stuff with them? So I'll let you continue.
Yeah. So by working on gaining rotation, some of the things that I see and I look for right away, does that improve their hip extension? Because my thoughts are, if I can get them to rotate in the direction they're not rotating, and we can get the opposite hip to extend where it's supposed to, we're going to take the pressure off of L5S1. We're not going to be grinding away at those little facet joints, and maybe they're irritable. So I look for those types of things. I look for that. Again, we go back to that overall patterning. And if I gain rotation there, does that improve their hip extension? And does that improve their lumbar spine moving out to the opposite side over there? Yeah. In other words, does that also begin to change the facilitation or over recruitment of the quadratus?
Right.
And so there's various ways to do this. Once I get a little bit of rotation, whether we're doing it with both feet on the ground and rotating, using eyes, using head, however, or we're laying on the side and doing some gentle contract, relax mobilizations to gain right rotation, and then getting back up on the feet, I like to be sure that I take the quadratus out of it. So that I can see what happens with pure rotation without the quadratus pulling the ribs down on the left side. So I put their foot up on a stool. Yes. So we get to work on single leg stance on the right. We need it on the left, but right now what we need is a different movement pattern. And so I put their foot up on a stool on the left side, and then I have them rotate right. And we keep working on that. And we do that on various levels with their stool up high and the stool down low, and then eventually standing on one leg. And then can they stand on the other leg, and what happens?
Yeah, and you could also get them in a standing on the right leg and put their left leg, just kneel on the stool, and get that stool back into hip extension and see if they can rotate that way as well. Yep. So, you certainly can. And you can do a partial lunge with their, with the foot up on the stool, so that they don't have to lunge all the way out, but they're in that lunge position. So if you're working with a foot, you're in a good position there for the foot to have to
gain control, because it's partially on the ground, the toes are tucked under, the toes, they're in toe dorsiflexion.
Yes.
So
Yeah.
and that they have to control it, that foot as well as the hip. So there's a lot of ways to work on that. And then, after you get the rotation, once I get the rotation, then I can start working on, like I said, getting over recruitment and under recruitment to change.
Yeah.
So one of my favorite things to do there is, single leg, lunging, those top of things that we talked about. I like putting the left foot up on the stool, because where we're going to head from there is we're going to be working on step up and step downs, because that's an important, meaningful task.
Yes.
And so that's where you take single leg stance and start to make it into a progression. And what I've found with people like this, that if I just have them do a little bit of external rotation, like when they put their left foot up on the stool and they rotate it outward a little bit, that they're able to go up and down with much less symptoms.
So you're saying their right foot's on the ground, their left foot's in a knee bend on the stool, and you're just rotating their body on their hip, so to speak, or their hip
I'm rotating their foot.
Oh, their foot. Got it.
On the surface. So we're actually asking them, not much, 10 degrees, just a little bit, enough to take those hip rotators out of, if you've got over recruiting hip rotators externally, and we're asking them to keep their foot straight, they're going to be working against that. That could be a source of irritation for them, because the muscles are wanting them to do the other. I say give into it a little bit.
Yeah.
So we can gain some hip extension, because one of the reasons they're not hip extending is because they may be those hip rotators are overworking and the abductors are doing nothing. So they're relying on those little muscles, and then they're putting them at a position where they can't work as well, and so it could be painful. It could make the muscle kind of be a little irritable and scream at them. So I just let them go with it a little bit. Like, I don't want them to go out 45 degrees, but just how far can we go that can help them gain hip extension and really help them actually turn that abductors on, because we take them out of their compensation. They can't drop off to the right and do all of these things, because we've gained the rotation back on the right side now. So now we've got to put the right input in to make sure that they don't lose their thorax off to the right or give into thoracic stiffness, so that they have to use those muscles around the pelvis to click in and really work. And so, and that's where the foot piece comes in too, is constantly watching that foot. Is that foot dropping into pronation when we take them out of that and put them in a little external rotation at the foot? Is that causing them to drop into pronation? What do we need to do there? Is it a foot control problem, or is it just that the pelvis doesn't have good motor control, and so the foot is being dropped down because of it?
Yeah, and I think because of all the activities that bother these people, they're mostly loading and weight bearing. The foot, at least in my experience, is most likely secondary in play, because that with that left foot back and into that left hip extension, that's a really hard position for the foot control. People tend to invert, plantar flex and invert. They just overactivate those rotators. And I think, doing anything, if you can take the foot out of it at the beginning, like go on a wheelie stool and take it out in terms of load, and clinically reasoned that if the patient's worse or no better, that way, then the foot could be in play. But I do think clinically reasoning, how can we unload the patient and see, piece out, not the word, but use a definitely more global approach to movement versus just a regional approach.
Right. And I think some of the things too that we've talked about that come into play here quite nicely is reach down, do a little lift if the foot's pronating, do a little lift under there to help them control it, see what happens. Does everything go crazy? Or does everything start to oh, that's so much better? And, so sometimes we can learn about, let's stay away from the foot if we try to mess with it. And
it could be worse.
The whole movement system, reverts back to that dominant pattern. But really kind of just helping them figure out ways to guide and to work that. So the other thing on single leg stance is you can also, on the side where it's not as optimal, the left side being in this particular case, is put the right foot on a stool.
Yes. Yes.
And so then from there, they can work on, can they bring their leg up underneath their pelvis? Can they bring it down? So you can work abduction in
Yes.
a functionally standing, position. And again, what's the next step? Step up onto the right.
Yeah.
And do they have the control now? Are they dropping and lagging? And that's why the thorax is going off to the side. Can they maintain the control as they step up on the right and step down from the, for the left to, come up and go down, with the right side being the loaded side.
Yeah.
But really you can work on, just how can they, get rotation in that position where they need it, and can the pelvis begin to gain some control, because it's not having to hold as much of a load. It's holding, because the stool is, the step is helping them, the weight of the leg and what the pelvis has to control is less because they're in that position.
Yeah.
But then that's where rotation has to come in first, I think. And because if they don't have that, they can't rotate to the right. There's going to be a problem there, because they're just going to collapse into that hip because they're going to stay left rotated. And, and then their leg is just going to power them up in the same old position that it's always done.
Yeah.
And we want that to change.
Yeah. They're going to just resort to an old movement, their dominant movement pattern, and just reinforce a non-optimal position movement for them, and I do think that, you would probably find the same movement pattern across all these dominant, across all these tasks. And, ultimately my patients are like, well, why are you doing this on this side? I'm like, well, because healthy systems need choices. It's up to you to take that choice, but you need to be able to have a choice for movement. You need to be able to get onto your left leg at some point, like to go down the stairs, like to single limb load. You can still carry your child on your right side, but you need to be able to train, I'm putting in air quotes, your other side. It's very important that you have that ability to move to both sides. It's a choice. So yeah. Go ahead. I'm sorry.
No, it's fine. It's totally fine, because this is what this is all about is, people just will sit there and ask me, like, where would you go first? Even though the question is, it depends, follow the movement pattern. As you said, look at it and see where it is across all of those movements: squat, bend over, step up, lunge, walking up and down steps, walking, sit to stand, all of those things. Even get on the floor and have them, get on all fours. Does it change it? Does the input into the thorax change? Is that a better position for the pelvis to recruit? If so, then they do better in flexion than they do in extension. How can we get them into extension on one side without the foot? So thinking about those, but the common denominator when I see this, I think, is primarily for me, is if I can get some rotation restored back in, then they are going to have to use different things. And I just need to be sure that I don't take that I'm constantly making sure that, because I gave them rotation, that it actually is improving or changing the movement pattern, and it isn't taking it away. So it's just an easy handle for me to start with, to kind of start picking up, okay, where's the real dominant pattern being stuck at?
Yeah, exactly.
If rotation doesn't change anything and that thorax is still sticking up into the right, I may have to go higher into the thorax and up, into the shoulder.
Up higher,
because the rotation didn't change anything in there. And, it may even make the hip worse. I don't know, so if you give them rotation and they start getting growing pain, it's like, okay, that's not going to work. Maybe we brought them into too much internal rotation by bringing them into this this right rotation of the thorax. Their hip goes into internal rotation when we rotate right. And that may really expose something like, maybe that hip has got a little bit of a, labral issue, or just doesn't really like that internal rotation piece in there because they haven't done it for so long.
Right.
And they're trying to, or maybe that's the primary thing, is that hip has got a little bit of some issues that we need to work, we need to do some joint work with, to make that better, because they may be doing this whole movement pattern to not have that happen.
Right. Exactly. I mean, ultimately, if you're making somebody worse by re-educating a movement pattern, you're obviously, maybe the right thing to do, but it's the wrong time, or the wrong thing at the wrong time. Right. So I think that's smart. And I also think, sometimes we have to treat a couple areas of the body simultaneously, depending on the person, because of the long injury history or movement history, because there are connections in the body. It just depends on the person. But I also think that because if you believe, like when you first start, we all have our biases, right, on what areas of the body to treat, and I try not to impose that on my patient. But you see, as a clinician, depending on how many years of experience you have, certain patterns that, and this is why I think you brought this up, there's certain patterns that we all see. And, everybody's, patient it's nuanced depending on their movement and injury history, but it's a pattern that you see. And so you want to rule that in or rule that out from the get-go, because then it'll make your life easier. If it's not, let's say, the thorax, okay, well then move on and then go down the next one on your priority list. How can you, if you restore the foot and it restores the right rotation, amazing. Then it's the foot, that type of thing. So the impairment still is loss of rotation to the right, but is intervening in the thorax the right way to go about it. And like you so eloquently said, you have to try that in all the different movement patterns, right? And so if you're making something worse elsewhere, like the foot's losing control, then maybe it's not the thorax that's driving that. Maybe it may still be, but I like that. I do. I think that's great.
Awesome.
Yeah.
So yeah, and then just then most people are kind of like, where do I go from here? And so as we talk about always, once you get the pattern to be changed, to change, then you want to load it.
Yes.
You're gonna guess what? We're gonna go back to carrying. And we're going to make sure that as soon as she doesn't put something in her right arm, that it, changes. Does she need to move it to the left? Can she move it to the left and go up and down the stairs? What do we need to train here? And what capacity needs to be built here for that person to be able to do the activities that they want to do? Perhaps maybe they want to run. What happened that we haven't even looked at running yet because she couldn't do it. It was so irritable, but now she's ready. What's going to be worse, going downhill or uphill? I can kind of think that it might be downhill, but maybe it's not. Once we get movement in and she starts to load in a quicker, no feet on the ground to 1 feet on the ground to no feet on the ground to 1 feet on the ground, and it's faster, can her motor control system keep up with it?
Yeah, and I would also say that don't be beholden, for the listeners, don't be beholden to, if you find out, well, the thorax is the driver, the foot's the driver, and it's the driver, and I'm going to keep, but as the person moves, and if they want to start running up and down stairs, the region of the body, maybe let's say the thorax, it may crop up here. If you found out that the foot was the issue, the thorax this may be the time to intervene when they start to load their system more, because they have more options for movement at that point, and they can adapt to load. Whereas at the beginning, they just couldn't really, I'm just using this as a hypothetical example, they just couldn't adapt to restoring that rotation directly into the thorax. You had to go the back door via the foot, for example. But when they start to do a higher load activity, maybe, and though they're going to have more robustness, their system will be more robust. So don't just say, oh, I'm going to throw the thorax out the door. No, that's not wise. I would probably think about at some point, going back to that and seeing if does this make them restore a more optimal movement pattern at a higher level, like you're saying, down like that, down the hill, for example. So I love these types of episodes, Susan, because I think it's great to group people, not group people, but you see a clinical pattern, right? Like, because we've been doing this a long time, and I think you see clinical patterns, and it saves you like time in your assessment. It saves, it's, as you mentioned, it's more efficient, right?
Right. As long as you recognize that it's a clinical pattern, but it may not have the same drivers and recruitment patterns and issues that may be coming from another person with the same pattern, but it gives you a place to start from.
Yeah.
And it gives me a place to kind of go, okay, let's see what gets worse and what gets better with this.
Yeah.
So that I can quickly say, all right, rotation was the way to go. Let's keep going with it.
Yeah.
Or nope, they can't do it. It's not, it's not working well for them. It's actually making some other things worse. Like I said, maybe the hip gets worse. We start adding rotation.
Yeah.
Like I could get them to rotate better as an impairment level, but then I stand them up and I have them rotate right, and the hip goes like, no. And it's like, okay, oops.
Yeah,
We gotta back out and come back. Yeah, but that helps me determine a lot better, like, okay, so maybe there's an issue here at the hip that is driving this whole pattern to be this way. So what do we need to do here? What do we need to do? What's happening here? What's working and not working around this hip? That they may be, motor control avoiding because they don't want that experience, so the brain is like, nope, we're not going to go that way. We're going to go this way.
And it may be so dominant that you have to unpack it, but that's where the clinical reasoning comes in, is that you see the clinical patterns, but not everybody has the same driver. That would be way too easy, right? In my experience, L5S1 is generally in the lumbar spine, not the driver in these people, but right, obviously. So, but that's the beauty of our profession, right? You're clinically reasoned through each patient. Each patient has their own story, and once you figure out their story, and they fit into sort of that. You see this a lot in this type of person, but this person has 3 kids instead of 1, and has had multiple ankle sprains, and the other person hasn't. They may have different drivers. They may have the same impairment, but they may have different drivers, and I think that's the beauty of all of this, right?
Yeah, 100%. And I think it's really important to just recognize that working, I get a lot of comments from my fellow colleagues saying, I've done the release of the obturator internus, I've gotten more hip extension, I've done this, we've done the work on the back, we've done dry needling, we've done all of this stuff, and they're still not better. And it's it's like, this all has to translate into a change in the functional movement pattern. So you can get the impairment levels better, but if we don't work on the functional movement pattern changes and how this all works together as a kinetic unit, we're probably not going to get the long-lasting change that we're looking for, or the changes in certain movement patterns that they're seeking. Same with the movement pattern. If we do something in the movement pattern and it creates something somewhere else, or it's not changing, because we may have to do a little impairment work and come back to that. But the whole thing is that it's not either or.
Right.
It's looking, assessing, seeing what translates across, and then starting to kind of take it apart and see what you can start to change, and looking for the greatest impact on the system that you can find.
Right, exactly. And exactly. Well said. And I think, you can waste a ton of time releasing obturator internus, and it's, as you said, it's not really it's a victim. It's not it's a victim. Right. So
it's working that way because it's being told to, and just changing it in supine or sideline doesn't mean that once you load everything up, it's going to stay that way. And, we see and hear this all the time. It feels so much better. And then as soon as I start moving, it's all back again.
Yeah.
And it's like, that's there's some dominance in that movement pattern that needs to be, as you always say, unpacked.
Yes.
And looked at.
And trained. So awesome.
Okay.
Thank you, Susan. This was lovely. Wonderful.
Yes, you're welcome. All right, everybody. We will see you on the website. And get in touch with us. Leave us questions. Leave us messages. Subscribe to us on our podcast, please, so people can find us. It's very important that we have subscribers on our podcast. And also we want to stay, and also where? Reviews. If anybody, reviews. So love them. Subscribe, review, like us, do all of those wonderful things so that we can keep coming back and visiting with you. Yes. We rely heavily on those reviews, guys. So if you haven't left one, please, we implore you, if you could possibly do that on Apple Podcasts, that would be great. Thank you. Bye.